and just give a shout out to our playlist today. And I want to promote our next webinar coming up the end of March. We will be talking about decolonizing global public health and really exploring how we get there, what it will take. We'll drop this URL in the chat momentarily, but we hope you will join us for this webinar in about a month from now. So here's a look at our speakers today, all representing Africa CDC. We have Jens, Dr. Landry, and Dr. Fifa. And moderating all of this wonderful discussion is my colleague at AVAC, Samantha Rick. I am going to stop sharing my slides and invite Samantha to take the podium. And thanks again all for being here.
Thanks so much, Jim. And thank you everyone for joining today. We're so glad to see such a broad and deep interest in these topics, and I'm not surprised. While I've been very involved in the global pandemic preparedness discussions, I often feel lost in the sea of different initiatives and new evolving positions and competing interests. I've heard from many of our partners that they feel the same way and don't know where to start or step in. A lot of the multilateral space has been focused on the pandemic accord for the past year, which, if you're unfamiliar and aren't waking up at 4 a.m. to follow discussions in Geneva like I've been, is a sort of a treaty, but don't call it a treaty, being developed by WHO member states to coordinate and drive forward global efforts to prevent, prepare for, and respond to pandemic threats. One thing that has been made glaringly obvious through experience with pandemics and in the pandemic accord discussions is that we cannot rely on so-called generous donors to support the functions of a global public health system. And that's been the driving ethos of Africa CDC's new public health order and its engagement with pandemic preparedness issues worldwide. So today we'll hear about what the Africa CDC is driving to ensure that Africa is prepared for the future. And with that, I will turn it over to our first speaker, Jens Pedersen. We did have one other speaker, but unfortunately he's had a medical issue and will not be able to join. So I hope that Jens can fill in and inform our audience a little bit about the new public health order and talk about some of the local manufacturing initiatives that Africa CDC is pursuing. Over to you, Jens.
Thanks, Samantha. And thanks, AVAC, for hosting us and allowing us to sort of speak to this important topic. So the new public health order is really the African push for a paradigm shift in global health. It was announced last year at the UN General Assembly, and it's sort of composed of essentially the way in which that we, from an African perspective, wish to see the global health agenda shift and be more inclusive in Africa. It's built on pillars that include manufacturing, that includes health workforce, that includes support for public health institutions and organizations. It's built on the need for meaningful and sort of transformative partnerships as well. And along with the broader African Union strategy of Agenda 2063, the new public health order informs Africa CDC's priorities for our pandemic preparedness, prevention, and response sort of framework and strategies. In relation to that, and sort of dwelling slightly on the manufacturing aspect of that, there's a few sort of key principles that underlies our approach, that underpins, our approach to manufacturing. One is that our approach to manufacturing is founded on improving African health security. Now, that obviously links to the experience during the pandemic, where Africa was excluded to a large extent and for a long period from accessing with the relevant tools, be those vaccines, PPEs, other medical equipment, and subsequently some of the therapeutics that were made available during the pandemic. So that's the primary principle, improved health security. Secondary to that is that in sort of service of African manufacturers and our member states, so the 55 member states of the African Union. And what we mean with that is we are looking, of course, to have a manufacturing sector that is African owned and that is in tune with African priorities. And in many ways, that is having a public health component, it's having a diverse capability and capacity of manufacturing that can be adapted when necessary in terms of pandemics, for example, in terms of other outbreaks. So a flexible and adaptive and Africa-focused manufacturing sector. The manufacturing sector, in sort of medical terms, where we are now at the moment, is, of course, depending on what product we're talking about. If we're talking about, for example, pharmaceutical manufacturing, there is a long history. There's a broad array and up to 600, if not more, existing pharmaceutical manufacturers. We'll come back to some of the realities of that. When we are talking about diagnostic manufacturing, the numbers are much smaller, obviously. And obviously, there has been a lot of focus on the manufacturing of vaccines, of which there is only a few existing, 3 to 4 vaccine manufacturers in Africa. There are many initiatives underway, but it's important to make the distinction that the approach differs depending on what sort of product we are sort of talking about. There are lots of sort of commonalities, and the sort of key driver of it that's going to facilitate, that's going to help us support is again, 2 underlying sort of aspects. One is the regulatory aspect, which pertains to quality, obviously. So the manufacturing and the product has to be of relevant and high standards and quality, which then entails, obviously, as well, that our African regulators, be that eventually the African Medicines Agency as it's being established, and our national regulating authorities, as we have in many countries across the continent, are capacitated in order to ensure quality as well. It also means that we are working hard on harmonization of the, let's say, the regulatory standards. As it is now, if you have a product, you have to do individual registration for several countries in the African market. That harmonization process is underway. So the regulatory and qualitative approach is one pillar. Another key pillar in this is the demand, the market access, which is really underpinned and has to be supported by our own member states. And what I mean by that is that our countries, our ministries of health, our ministries of finance, our heads of state has to agree to want to buy African. If we cannot agree to buy our own products, it's very difficult to convince and to argue that donors, the other large procurer, whoever they may be, PEPFAR, Global Fund, UNICEF, Gavi. So it requires a change and a shift in approach on the demand and market side, which is that we as Africa have to agree and have to, in some instances, find ways of paying the price that it will entail to buy products made in Africa. Some of that, of course, lies in us at Africa CDC within our structures working on consolidating and coordinating demand so we can pool procurement. We have as I'm sure some of you or many of you will have seen in the recent AU summit or the AU assembly, which took place 2 weeks ago, Africa CDC was mandated by our heads of state to establish and incorporate a pool procurement mechanism. We were given the mandate to expand our focus from vaccines to therapeutics and diagnostics, so medicine and other products. And Linked to this, there were appointed a number of champions for health issues, one being a AU high-level champion for African manufacturers, which is the president of Kenya, William Ruto, and an AU champion of pandemic preparedness, prevention, and response, which is the president of South Africa, Cyril Ramaphosa. So our role as Africa CDC in all of this is, with these mandates and with the under sort of pinning principles and guiding sort of aspects, is to now, in the short and medium term, drive some very focused and very hard priorities. It's very obvious and it's very clear, as I'm sure you've seen as well in most of your work, those of all of you who are on the call, that the interest in pandemic response, the sort of momentum is waning and it's disappearing. The window, as we call it, for support of African manufacturing is slowly closing. It's not going to stay open forever. So our focus is very much within the next couple of years. With vaccines, it obviously takes a while, whereas with pharmaceuticals and diagnostics, we have existing products. But to really get some manufacturers over the finish line with regard to the regulatory and quality standards, and with regard to implementing our mandates on full procurement. I'll give a good example of that, which is an issue which I think from an advocacy perspective is very important as well, which pertains both to the pandemic aspect and to the manufacturing, which is the manufacturing of cholera vaccines. Many of you will have seen in the news that there is an ongoing cholera outbreak in the Tsague, so in the Southern African region, which is one of the worst that has been going on in many years. There is a global shortage of cholera vaccines, so much so that the protocol for using cholera vaccines in outbreak context, which usually requires 2 dosages, has been reduced to 1 dose. So we are faced with a situation where we have an ongoing and acute outbreak with a global shortage and almost absence of one of the key tools in an outbreak response, which is the cholera vaccine. And we have a process of technology transfer into Africa manufacturer of the cholera vaccine. So AVAC in South Africa has an agreed technology transfer and is working on it. But it's a process that takes time. It's a process that needs resources. It's a process that needs support. And it's a perfect example of how we now are seeking, but also are asking the help of our partners to come together around these shared priorities, which is to say, we have an acute problem now, let's push this product, in this case, the cholera vaccine, over the finish line as soon as we can, obviously without compromising quality and safety. In some cases, the technology transfer do take quite a bit of time, but we are looking at identifying and have identified similar sort of products and categories where we are saying we are looking at getting African existing manufacturers over the line. One, because there are the acute needs, and two, because of the sort of closing window of opportunity within which we have to deliver as Africa CDC. And in some of these, which is why I think this webinar and this call is very important as a sort of global advocacy community. We have to work together, and we will be asking for support in maintaining the political momentum and support for African manufacturing, whether it's advocating towards WHO for pre-qualification, whether it's advocating towards our member states to actually buy these products when they're available, or it's, and importantly as well, advocating for concerted financial support to unlock some of these challenges that the manufacturers are coming across when they try to scale up and when they try to improve their manufacturing. So I think, Samantha, with that, I'll leave it And I'd like to say, certainly it's a platform and it's a network that we as Africa CDC are very happy to stay in dialogue with, because we will rely on your help and support in advocating for the priorities of our manufacturing, for it to have the public health impact that we all wanted to. Thank you, Samantha.
Yes. Thank you for that presentation, Jans. I wonder if you could talk a little bit more about this closing window of opportunity and what's influencing that, and why Africa CDC has to move so quickly on these.
I mean, we all have short memories, and politicians' memories are even shorter, right? And we see it with regards to manufacturing. We also see it, you mentioned some of the processes in Geneva, and Fifa will talk to them later, about the pandemic treaty, how, for example, with regards to the pandemic treaty, there is very tight deadlines that are set to finalize the process. Whereas from an African perspective, we may say, actually, we need more time because we are building a system. For us, we're not rushing to build our manufacturing as much, because we are talking about building quality. We're not rushing to get agreement necessarily on the pandemic treaty, because we want to make sure that equity, we want to make sure that pathogens and benefit sharing is in our interest. And sometimes rushing things is contrary to that. The closing sort of window with regard to manufacturing is stemming from the same reasons, which is that, well, the world has moved on from the pandemic, because many parts of the world have forgotten already, and they don't necessarily care that in order to change the response, we have to do things differently. That is building regional manufacturing. It's getting a pandemic treaty, for example, that is adequate to what we need as Africa. And it's, as Landry will talk about as well, it's about making sure that the processes and the instruments, such as the pandemic fund, are attuned to what it is that we are challenged with in the developing world, and especially from Africa CDC, from an African perspective, obviously. So the short answer is that sadly, a large part of the world has moved on from the lessons from the pandemic, and we are trying to make sure that we still get some changes in the global health system and in the global financial system and the global manufacturing system that can make sure we have a better response next time.
Great. And before I let you go from your presentation, can you talk about how advocates can engage in Africa CDC's local manufacturing pushes? Who can they talk to? Who needs to be convinced? Where can they input?
So as we are now sort of embarking on the more detailed aspects of developing and the practical aspect of developing pool procurement, we are in dialogue with various actors across the spectrum. If there's anyone that wants to engage further, please don't hesitate to reach out. I hope that contact details will be made available on this platform. If not, I consent to that herewith. So anyone, please feel free to reach out to any or all of our colleagues, and we will do our best to make sure that the voices get heard and included. The best, I think, the short answer and the best way is to make sure, one, that we maintain a public health and a health security approach to our manufacturing. So that's one sort of request that we will carry forward, and we will ask all of our colleagues on this call as well to keep carrying forward and to keep emphasizing. We have to make sure that the manufacturing we build and the manufacturing we expand has a public health component, and that it's in response to African health needs. We are not looking at just transplanting what has existed elsewhere.
Great, thank you. We'll now turn to Dr. Landry to update us on the Africa CDC's push to be an implementing entity for the pandemic fund, and how the Africa CDC is planning on engaging with these financial mechanisms in the future. So to Dr. Landry. maybe. Is Dr. Landry still with us? There he is. Okay, great. You are on mute. There you go.
Samantha, can you hear me?
Yes.
Great. Good afternoon, good morning, good evening, depending on where you are following this important webinar. I think I was already introduced. Landry Tsague, I'm Senior Advisor with the Executive Office of Africa CDC. And thank you to WACI Health and RANA for inviting us in this webinar. I was asked to talk about Africa CDC engagement with the Pandemic Fund. So let me say, first of all, I would like to structure my presentation in basically 4 points. The first one is to take a step back to talk about Africa CDC and the strategic plan of Africa CDC for the period 2023-2027. And then I will link it with the engagement of Africa CDC with the Pandemic Fund from the first round to the second round, which was announced last December. And then I will then move to explain a bit more what Africa CDC and key partners like WHO has established through a partnership platform called the Joint Emergency Action Plan, in abbreviation JEAP, to really strengthen coordination for emergency preparedness and response on the continent. And building on the JEAP, I will explain how we are putting together a common Africa approach to respond to the second call for proposal to the Pandemic Fund. So in terms of Africa CDC strategic plan and positioning, I'm sure you all know today that Africa CDC was established in January 2017 as a specialized technical agency of the African Union. The Africa CDC has been entrusted with the primary mandate of safeguarding Africa's health security. Despite facing resources constraints and a limited workforce at the beginning, Africa CDC has demonstrated the power of regional coordination in response to public health emergencies. Consequently, Africa CDC was elevated to an autonomous health agency of the African Union during the 26th Ordinary Assembly of Head of State and Government in February of the year 2022. At that new status guarantee its agility and empowered Africa CDC to effectively respond to member state needs on the continent. And I think this is important to have as a background because it also sets the positioning of Africa CDC with global mechanisms like the Pandemic Fund. So as you know, the Pandemic Fund issued its second call for proposal last December with a total envelope of 500 million. The fund is currently open for applications, accepting the three modalities of applications: the country-specific applications, the multi-country applications, and the regional entity applications. I also want to highlight that Africa CDC is now an observer in the board of the Pandemic Fund. And I'm also pleased to share that Africa CDC has officially applied to become an implementing entity of the Pandemic Fund in Africa. And we keep you posted about the outcome of that application. I think the third point or the third segment of my conversation is about how on the continent Africa CDC, building on its renewed, upgraded status and its unique mandate, is strengthening the continental coordination around preparedness of and response to emergencies. So I want to really highlight the JEAP initiative. JEEP stands for Joint Emergency Preparedness and Response Action Plan. It was established, co-created by Africa CDC and WHO Afro is for the Africa Sub-Saharan region, and EMRO which includes the Northern Africa. And this is really a continental platform which provides clear direction on how to jointly prepare and respond to a public health emergency on the continent. And the action plan that is called JEEP was launched May 2002. Yes, in May 2003, we are 2004 now, but the development started in 2002 in the midst of the COVID-19 response. I think it's important to have the perspective of how Africa CDC is strengthening, first of all, the continental coordination around preparedness and response to public health emergency before we delve into how does that link to the pandemic. Let me also highlight the fact that our continent, Africa, experiences more than 166 this is for last year, 166 health emergency in 2023. And this represents an increase from the year 2022, where we had recorded 100 health emergency events. So it's clearly an indication that the continent is continuing to face extreme strength due to health frequent and increasing frequency of health emergency, putting a strain on our health systems, putting a strain on our economy. And we all know the increasing impact of climate change-related events, as well as conflicts on our continent, further aggravating the situation. I think these contexts heighten our vulnerability to disease outbreaks. So within this framework, it's clearly a need for us on the continent to revisit the way we prepare and respond to public health emergency. So the JEEP, as I mentioned, is a platform. That partnership is intended to support all the 55 African Union member states to build resilient systems for preparedness and swift and effective management of public health emergency. But what the JEEP is also is a tool for resource mobilization for regional level initiatives that will benefit the African Union member state. So the JEEP exemplifies what I mentioned earlier. Africa, I think it was already mentioned by Jens, the Africa CDC vision for a new public health order. And it brings a unique platform for partnership, as I mentioned, with WHO, Afro, and EMRO across the entire continent. And through the JEEP, the intent is to really support the African Union member state, the other key stakeholders, to catalyze investment and further foster multi-sectoral, multidisciplinary approach and having a whole of society approach to health security in Africa. So the JEEP is also intended to build the backbone of and become a connector that glues our collective preparedness. And I really want to emphasize here on the civil society, because I think this call is also about how do we bring the civil society actors and stakeholders in the whole preparedness and response to public health emergency. And I'm very happy to have a further discussion with key civil society actors on how to play a key role in the JEEP platform. So how is the JEEP linked to the Pandemic Funds Round 2 from an Africa CDC perspective? You all know that from the first round of applications, Africa was the only continent without any successful regional or multi-country proposals. That we know it. But we also know that we were fortunate to have 5 countries on the continent: Burkina Faso, Cabo Verde, Ethiopia, Togo, and Zambia, with successful applications. But we are mindful of the fact that there were many applications from our member states, close to, I think, if you take the case of a country like Ethiopia, there were almost 17 applications from Ethiopia. And what we also learned is that there were difficult, let's say the coordination was very inefficient at country level, not even saying at continental level. So learning from that, and in order to have quality applications that respond to the need of the member state, to the needs of regional economic blocks, Africa CDC came together with WHO using the umbrella of the GIP to co-create what is called a Common Africa approach for the Pandemic Fund Round 2. So the Common Africa approach really is intended to foster a coordinated approach for identifying the priority needs for proposal development and putting together a capacity to provide intensified support to member states and regional entities putting together proposals to the pandemic fund. So with that in mind, what we were able to do with WHO leadership and the leadership of Africa CDC includes, first of all, we had a briefing with all the 55 member states to describe what, as Africa CDC and WHO, we intend to put together differently for the round 2 to ensure that the continent collectively identify the priorities for proposals to the pandemic funds and bring the quality support to the member state as well as the regional entities to submit competitive applications. So the briefing was done with, as I mentioned, the ministers of health of the 55 member states. And we last week we had a briefing with the regional economic communities leadership, as well as the AU specialized institutions. The intent is to make sure that as we move towards defining the focus of proposals from the continent to the pandemic fund, we reduce duplication, we foster synergy and complementarity between country-level proposal, multi-country proposals, and regional entity proposals. Where we are today, we are at the stage where the team from WHO and Africa CDC has identified the priority thematic issues, which are based on our collective intelligence on the issues on the continent in relation to public health emergency. If we collectively come around those 8 issues, we can respond to the needs of our member states, both at country level, multi-country level, and at regional level. So next week, we expect to have an analysis of the feedback from the member state and the regional economic community, as well as African Union specialized institutions around their interest in those 8 big tickets. And with that in mind, we now organize the technical support, which is already in place at WHO and Africa CDC, and will be further expanded to include other expertise from key partners on the continent to provide intensified support in the during the months of March and April to ensure that by mid-May, the number of proposals submitted from the continent are going to be very much speaking to the principles of priority, synergy, complementarity, and quality. I think this is what we have prepared for this conversation, and I look forward to the discussion with key partners from the civil society about how to engage with the budget process and the Pandemic Fund Common Africa approach. Thank you.
Thank you. Thank you for that presentation, Dr. Landry. And you've talked a lot about civil society engagement with this. What do you think is the best way for civil society and communities to engage in the Pandemic Fund, either through the Africa CDC or to advocate to the Pandemic Fund for Africa CDC's inclusion?
No, it shouldn't be one way or the other. It should be both. I think the first principle is that there is no effective preparedness or response to a public health threat without the involvement of the community. And as we say in epidemiology, basic epidemiology, an outbreak always starts and ends at community. And without the involvement of community key actors in the process of designing country-specific proposals, multi-country proposals, and regional entity proposals, we'll be missing a key principle around learning about our context with the community and preparing better to respond to threats with the community. So they are welcome, and I'm looking forward to have follow-up conversations with those who are connected. Thank you.
Great, thank you so much. Now we will turn to Fifa Rahman to discuss the Africa CDC's positions on multilateral negotiations, for which she is consulting. Off to Fifa.
Hi, everybody. Thanks so much, Sam, for the invitation to join this meeting today. As mentioned, some of you may know me from a different role. Today, I'm speaking to you as Pandemic Negotiations Consultant for Africa CDC. A little proviso before I begin, which is what I tell you today isn't the African group positions. This is what we would like to see occur in the pandemic accord, and I'll run through maybe 3 to 4 positions that we'd like to see for the Africa group. So first of all, PABS is at the heart of the political bargain for the pandemic accord. And essentially what we want to see, the basic premise is that pathogens that are shared by labs or by anyone with the database and are later developed into products that are used and are beneficial in a pandemic should be attached to the benefits of the people, right, or whoever who donated to the genetic sequence data or the pathogen data. So this could be via technology transfer, or it could be via certain donation, 10% of their products to WHO, or via, for example, selling the products at affordable or cost price. So there are various benefits that countries can achieve. However, and I'm here in Geneva, 2 days ago, a new text on PABS was released, and it was, for lack of a better word, just simply not what we wanted. It incorporated many positions from the EU, and we felt wouldn't be able to deliver something that is equitable for Africa. Now, what do we want? So the current text that was released 2 days ago, which was essentially rejected by Africa Group negotiators, is that the sharing of the pathogens is more or less obligatory, but the benefits, the language around the benefits shall facilitate, and sort of softer language like that. So there needs to be a changing of the asymmetry in the language at this stage. So at this stage, only pathogen access is obligatory, and the benefits are using softer language. So either one of 2 things needs to happen. Either both become obligatory, that if you use a pathogen or a genetic sequence data that comes from, say, Africa, and you develop a product that is now used globally, such as a vaccine, based on that genetic sequence data, then it should be obligatory that you give benefits as well. So you either go up to the obligatory standard, or you bring the pathogen sharing down to the facilitative standard, right? So that countries can choose whether or not to share the pathogen with the database. and then you can facilitate or not benefits, right? So one of two things needs to happen, and this is clearly, given what happened in COVID, clearly, quite a strong it really is at the heart of the pandemic accord. And if we don't have a resolution on this, I don't know really what's going to happen in May. So it is incredibly important. Now on One Health, which is Article 5 and 4 of the pandemic accord, I'd like to dispel the notion here that you kind of hear a little bit that African member states are not interested in One Health. That's incorrect. In fact, Africa CDC has a department working on One Health, and countries are implementing different elements of One Health. But the devil is in the details. And in the text, in both Article 4 and 5, there are there's quite strong language around enhanced collaborative and integrated surveillance, as well as the need to develop, strengthen, and maintain pandemic prevention capacities in List X. So List X is quite important because there's no such list at this stage, and it's concerning that African member states might have to come up to a number of capacities and competencies that currently are unknown, on top of their competencies and capacities that they have to adhere to in the IHR. So, from our point of view as Africa CDC, we need to see detail as to what those capacities are. And there are also those questions about whether capacities belong in the treaty at all because of the character of Article 19 and Article 21 regulations, where the legal character of Article 21 regulations are more about prevention and capacities and all that kind of thing. So where is the legal home of capacities, competencies, especially as regards to prevention, is something that we need to think about as well. So the fact about One Health is it's not that African member states don't want to do One Health. The opposite, the One Health is already being implemented in different ways. But the burden of responsibilities and the burden of obligations upon African member states is something that has to be considered, especially as regards interoperability on surveillance for animal, plant, and environmental surveillance, right? Because these are highly burdensome. And even like, we're not even talking about, say, Central African Republic. Even if you look at the larger countries like Nigeria and the wealthy countries, it would be a challenge to have interoperable systems on human, animal, and environmental surveillance at this stage. So there are things that need to be sorted out in that. So I've got 4 minutes left before I have to leave for another meeting. But on financing, so that we don't know if there's an appetite for a new fund at all. What we're hearing is that there are some parties that consider the pandemic fund to be sufficient to respond to surge capacities and to be used for the increase of competencies related to the IHR and related to pandemics. So from our side, this is a question about representative governance and whether a pooled fund within the WHO pandemic accord, or whatever it's called in the end, would be more representative for African interests. So that certainly is an issue. And we need to seriously look at the financial issues, because if it is interlinked with other things in the agreement. So if we take on, as a continent, stronger and more cumbersome requirements on One Health, that includes reporting whether annually or biannually, on what capacities and what competencies, what we've achieved on One Health. That requires financing. So if it would be a challenge for wealthier countries, you can also imagine how difficult it would be for, say, a Madagascar or another country at the lower income levels. So financing is incredibly important. And if there's no financing, there's simply no way that some African member states would be able to achieve these cumbersome requirements. So I want to leave 2 minutes to allow for a question if needed, but otherwise my apologies, but I do have to leave early for another meeting. Thanks.
Yes, so FIFA does have to leave. If you have a question for FIFA, please put it in the chat right now. I will ask you, FIFA, the same question I've asked everyone else. If civil society and communities want to get involved in Africa CDC's multilateral negotiations, how can they do so? And what's the best path?
So because we're not negotiating, we are advising and we're providing technical advice and support to negotiators. What we need more than anything is analysis of provisions and sort of external pressure and certain things. So equitable finance and governance in financing, for example. Anyone doing an analysis on One Health and where One Health standards are across the continent and how quickly we can reach the One Health standards as currently written in the pandemic accord text. Certain technical support like that, but also external pressure on dispelling the notions that it's Africa blocking this agreement, because it really isn't. And like Jens said, it's equity takes time to negotiate, and rushing to a conclusion isn't necessarily within Africa's interests. So thanks.
Great, thank you. So Jans and FIFA have to jet to another call. And I know Jans has been answering a lot of the questions in the chat, so hopefully a lot of the questions directed towards him will be covered. I've got some questions from our participants that have registered on Zoom that have already submitted, and those questions will go to Dr. Landry, and then I'll open it up for just a group discussion and some strategizing among advocates around these issues. So Dr. Landry, right now, African governments are yet to allocate their 10% of their GDP to health, as we know. How can pandemic preparedness be actualized through Africa CDC's plan? And what type of innovative financing is available so that Africa can reduce reliance on the global north?
I had a connection issue. Can you please come back with your question, Samantha?
Sure. African governments are yet to allocate the 10% of GDP to health that they've committed to through the plan. And so how can pandemic preparedness be actualized through Africa CDC's plan? And what type of innovative financing can help Africa become less reliant on the global north?
Okay, thank you. Thank you for the question. I think you are really touching on an important pillar of Africa CDC's vision for a new public health order, which stands for public health in Africa has to drastically shift from being significantly dependent on donor resources to being more significantly dependent on domestic resources. And as you rightly said, one of the declarations that the African head of state made a few years back, I think 2015 in Abuja, was to increase the allocation to the health sector to meet a threshold of 15% of their domestic resources. We have to acknowledge that there are countries on the continent which have reached that threshold, but there's still a significant number of countries where the allocation to the health sector has not reached the 15%. I think you mentioned 10%, but the commitment was 15%. Now, there are definitely challenges into that. And one of the realities is that the fiscal space in many countries on the continent has gone through significant reduction, and that we cannot underestimate the impact of the last COVID-19 pandemic on the economies of many countries globally, but more specifically countries on the continent. And then the second point around the constraints or the challenges is definitely the debt crisis. I think when you look at most of our countries, there's a persistent debt crisis. They have to juggle between financing priorities, especially social sector priorities like health, and reimbursing the debt. The debt crisis is definitely one where we need to, as we think about innovative financing, we definitely need to think about how do we transform the debt into a source of investment into strategic sectors like pandemic preparedness. And I think that's a conversation that I know is ongoing with the head of state on the continent, engaging with their peers in other regions of the world to talk about redesigning and redefining the global financial architecture. I think a lot of innovation will have to be driven not by the community, but mainly by the global conversations as well as the continental conversation. The third point I really want to highlight here is regardless of what will happen at global level, we are at the level of the continent, Africa CDC and the African Union, learning from the COVID-19 response and also learning from, as I mentioned earlier, we only got 5 countries out of 55 being funded through the pandemic fund. It's a clear indication that if we only have the pandemic fund as the sole mechanism for pandemic preparedness and response, we will not meet the needs of our member states in case of a pandemic. So the head of state came up to endorse the Africa Epidemic Fund at the last AU Summit and instructed Africa CDC to operationalize it. And the Africa Epidemic Fund is another mechanism to really create a fund that will allow Africa CDC and the member state to have access to flexible resources to enable not only preparedness, but also rapid response to any public health threat. Thank you.
Great. And sort of a follow-up to that one, a question from Tarita in the chat. Could you elaborate more on the role of the Africa Epidemics Fund in support for African pandemic preparedness and how those synergies could be created with other instruments between maybe the Africa Epidemics Fund and the Pandemic Fund?
I'm not sure I got the question clearly.
Can you elaborate more on the role of the Africa Epidemics Fund?
Okay, yeah, definitely, as I mentioned, the Africa Epidemic Fund was built up as a learning of what happened during the COVID-19 response. Because during the COVID-19 response, the African Union established a COVID-19 fund. That COVID-19 fund was very instrumental in not only mobilizing resources from the private sector and obviously member states, but also making available to key pillars. I think the access to commodities was critical, and local production during the COVID-19 response was also critical. So that fund was instrumental in providing catalytic investment of resources to actors on the continent. Now, learning from the success of the COVID-19 fund, the head of state elevated it to cover all the epidemics and pandemics, of course. So the Africa Epidemic Fund will, the operational modalities will be described further and communicated in due time. But the intent is to add an instrument to, let's call it the set of instruments that should be available at continental level to provide rapid access to resources for effective preparedness and response to any public health threat.
Great. And this next question is also from the chat from David Bryden. And I pose this both to you and to members of the audience if you have inputs on this question. In the US and UK and Japan, we're seeing this massive wave of chronic disease as a result of COVID. This is long COVID, includes vascular and cognitive impact, diabetes, immune dysregulation, et cetera. What, if anything, are you seeing in the African region among health workers, teachers, other members of the population? Is this something that's coming up?
Definitely, this is a priority for, let's say, the public health community. And Africa CDC, working with member states through the surveillance system that is in place and collaborating with WHO, monitoring closely the chronic conditions associated with long COVID. I think the data on the continent will definitely be published in due course, but this is a top priority for the continent, as mentioned by the participant. Thank you.
Thanks. And I know a lot of our audience members are based in Africa. If you have any inputs on this question or other questions to ask. If not, I've got a whole list, so don't worry. All right. Dr. Landry, does Africa have the legal frameworks to guide and inform pandemic preparedness as is, or do those need to be still developed?
Are you referring to the pandemic treaty, or are you referring to the pandemic accord?
Just national legal frameworks. I know there's some problems with, compulsory licensing or tech transfer, where some countries' actual laws maybe prevent that from happening, even though they are allowed to by the WTO, or if they have legal frameworks to facilitate regulatory harmonization. Are those in place, or do those need to be developed?
No, this is thank you, Samantha. This is a critical question, which is part of the ongoing negotiation at global level. I think the best way to address this, as guided by the leaders on the continent and globally, is to move forward to revising what is called our international health regulation on the one hand, and on the other hand, negotiating a pandemic treaty or pandemic accord, as my colleague previously mentioned. I think that's the best way to address a framework which will bring all of us together, because going country by country will not be the most effective way. Pandemics or epidemics, they don't know borders, and we need to really look at it collectively.
Great, thank you. All right, we have questions from the audience. Thanks you all. I turn to Chris Collins.
Hi, thanks so much, everybody, for this really great discussion. I wanted to get the perspectives of as many speakers as possible about your views about how different entities working on preparedness can be coordinated, particularly, the Global Fund and Gavi and other programs do a lot of preparedness relevant work. A third of Global Fund investments are related to preparedness. How can their investments be coordinated with the Pandemic Fund and with Africa CDC and any new funds related to preparedness? What's your vision of how existing programs, how they can play a role in preparedness alongside others? Thank you.
Can I come in, Chris? I don't know.
Please.
Yeah.
That'd be great.
Yeah. No, Chris, I think you are touching on a critical point. If I take a step back to explain why at continental level it became critical that we will not continue doing business as usual around coordinating our pandemic preparedness or public health preparedness and response and expect a different result when the next pandemic hits or when the next epidemic hits. So the Joint Emergency Action Plan has that intent, it to serve as a platform to strengthen the coordination around the pillars from preparedness through the response to public health outbreaks and public health threats. I think the point you're making is also critical because preparedness when it comes to public health threats is about the systems strengthening. And primary healthcare in Africa, it became clear during the outbreak of the COVID-19 pandemic that most countries where the public health system was very strong did not sustain the type of negative impact as where the public health system was weak. So preparedness has to do with how do we leverage the investment that goes towards primary healthcare, towards the workforce development, towards the financing on the sector, as was mentioned earlier. Preparedness is everything that talks to investing to prepare the local manufacturing is part of our preparedness. I think this is clearly a space where in Africa CDC today the leadership is clear about the local manufacturing being seen as another independence way for Africa. And the leadership of member states is clear about local manufacturing because they understood that there is no preparedness without commodity. There's no preparedness without equitable and accessible commodities for all the threats. I think preparedness also brings in the issue of knowing your epidemic and knowing your context and predicting the next epidemic and putting in place the whole end-to-end platform which will allow you to develop your solution within the next 100 days of the identification of a threat. I think we have to come together. I don't want to list partners or stakeholders here, but the principle is that moving alone around preparedness would just make us lose time and waste a lot of resources. Thank you.
Great. Thank you, Dr. Landry. I also will needle Agre to share his views on this question when he does his conclusion remarks, because I know he has some. Nahashan.
Thank you so much, Samantha and Dr. Landry. From the lessons from the first call for proposals of the pandemic fund, one of the issues that emerged was the participation of civil society organizations in the proposal development process at the country level. And it's really great to hear the plans that you have and the engagements that you've been having together with WHO Afro in guiding countries in the second call for proposals. Just wondering whether, in the engagements around the second call for proposals, there is a prioritization for engagement of civil society organizations in the development of country proposals, and do you see an opportunity for CSOs in development of multi-country and regional proposals if we get to that stage? Thanks.
I think the answer to this question, Sean, is clearly indicated in my previous statement, which is this is the time to have in-depth conversation about the critical issues around the three pillars of the pandemic fund: lab strengthening, surveillance strengthening, and workforce development, where civil society on the continent are already doing significant work, and where they would like to come together to either support or being part of multi-country proposals or part of regional entity proposals. But definitely we believe country level proposals or country specific proposal development, one of the requirements of the pandemic fund is to demonstrate civil society engagement. So I think that one is definitely being it's an ongoing process. But what you haven't seen yet, and what we want to promote, is working with civil society organizations with a regional or continental scope. Looking forward to that.
Great, thank you. Excel.
Thank you. Thank you for the presentations. I have two questions regarding the pandemic treaty negotiation and the IHR revision. My question is, what will be the worst scenario for the Afro group? And the second one is, what can the Afro group can do in case of the worst scenario happen? Could he call to a no vote so that the consensus will fail? Because what is the utility to vote for a treaty that does not meet one priorities? So that is really, it is on the political point of view. Thank you.
All right, Dr. Landry, to you, and then I will also take a soapbox on that one. Oh, Dr. Landry might be frozen. There you are. Okay. Dr. Landry, can you hear us?
I can hear you. Can you hear me?
Yes, I can hear you now. You froze for a minute.
Was there a question for me or I missed it?
Yes, it was asked, what is the worst position for the Africa CDC on the pandemic accord and IHR? And is there room for them to say, no vote, we won't pass it if it comes to that worst position?
Let me put my video off. Is it better now? Can you hear me?
Yes, we can hear you.
Yeah, sorry, I had an issue with my connection. So the question is about the worst case scenario.
Worst case scenario for the pandemic accord and IHR, and whether Africa Group would take a no vote or not pass the pandemic treaty in that case.
I think let me just share that at the last AU assembly in February, are we in February still? Yes, we are still in February. So a few weeks ago, the head of state endorsed an African position, a common African position to the pandemic accord negotiation. So I think it's critical to understand that we are very much optimistic that that common position will meet the other negotiators' position, and we will definitely not face a significant challenge towards the May deadline. That's what I can say.
Great. And then I also have some views on this. I think this is one of the points where we can turn to a sort of audience group discussion. I mean, I think from what I've gathered, a worst case scenario would be a treaty that obligates all of Africa to share pathogen data without anything in return, does not have any access conditions in publicly funded R&D, does not support human rights, does not have any funding or financial commitments attached, all of which are very much real possibilities at this point. There doesn't seem to be much agreement on any of those topics or room to come together yet that's been signaled. And I think that the second part of the question, can they just walk out? I mean, yeah, that's the best leverage I think that Africa Group has right now. The US and Europe really want an agreement by May, partly because the US has elections this year that could be very consequential and completely change how the US interacts with the pandemic treaty or any other multilateral treaties if we interact at all, depending on who wins that election. So I think that's a really big point of leverage that Africa Group has. They can say, you know, we won't have an agreement at all if we don't meet XYZ. And that's something that the US and Europe really need to strongly consider if they want the US and Europe to be a party to this agreement. Fitsum, I don't know if you have any views on that subject as well. If you're here, or if anyone else has views on that subject, please chime in. I don't know, Joelle, if you had other views on that as well. It seems like you have some opinions.
Thank you, Samantha. I'm here.
Great.
Unmuted. I was on mute while trying to address it. To be honest, I don't have much more on that view, but just to also thank very much Africa CDC, and also to reiterate that the civil society were always here to support and also to complement actions that Africa CDC is taking, especially on the new border, and also to see how negotiations would be much more fruitful. So it's more of thank you so much.
Thanks. Joelle and Excel, I don't know if you want to contribute to that as well.
Yeah, just to reiterate what you mentioned earlier, that walking out, I think, would be the best scenario if things continue the way they are at this point. I think the African group should really consider this position. Walking out doesn't mean it's not a failure, like it's just standing by your point, you know, just trying to get your point across. I think walking out would probably just send a clear message that all of this needs to be renegotiated. Yeah, thank you.
Great, thank you. Oh, Excel, go ahead.
Yes, thank you. I think that it is important to stand firm on what each region priorities are. The point with the pandemic treaty, even with the IHRs, is that regions across the globe are coming together to decide what will be the most important thing. But with the IHR 2005, we already saw that during the first 10 years of implementation, the African priorities were not included. So what is the point to just go forward with such a stance where you go and you just ignore your own priorities and get other regions' priorities the first place? It makes no sense. I don't know the political, what is being said into the corridors, but according to me, at WHO, it is one country, one vote. African region is 49 countries at WHO. 49 countries is a lot of countries. So yes, it could be a good strategy, but it will also mean that we fail to stand together and to recognize that the local comes before the global.
Great, thank you. And with that, I think it's a great note to turn it over to Agre for concluding thoughts.
Thank you, Sami. Thanks everyone for this very insightful conversation. I think we have touched on a number of very important things. I will not attempt to summarize the discussion, what has been surfaced in this very rich discussion, but just share some of my overarching thoughts, from what I've had in this call. I think it's very clear, and building on our experience from the pandemic, that really what we are dealing with, particularly in the context of really supporting the Africa CDC and Africa Union's call for new public health order, is legitimate call that requires everybody's support. I think all of us are in agreement with that. And this is one vision that requires the actual, exercise of the whole of society, whole of government approach, so that we all in support and drive the necessary action that is needed to help this vision become a reality. We know where we've come from, and we know that we're not out of the woods yet. We have witnessed the conversations that are happening at the INB process. The areas that are really promising the transformative, potentials are the ones that are contested. The issues that really would deliver equity in action are the ones that we are not having consensus on. And we see a lot of tendencies towards the very, I don't want to call them wishy-washy, but, provisions that do not have actionable, imperatives. Shall, will, not even will, shall, should kind of framing, which have no accountability or enforceability imperatives around them. And what I think Africa needs to be alive to, in as much as we're making demand at that global level, really the solutions must be homegrown. We must demonstrate commitment to really driving our vision. And this ownership must be demonstrated in terms of our own allocation of domestic resources. This ownership must be demonstrated in terms of how we cultivate relationships with our partners. And this relationship must be redefined so that they are not the philanthropically, charitably framed kind of relationship, but relationships that are based and premised on solidarity, that are premised on the understanding that we are as strong as our weakest link in terms of pandemic threats. And preparedness means all parts of the world, the richest, the poor, must have the necessary countermeasures and capabilities to detect and contain threats before they become, pandemic. And this is something that we should devote most of our energies, even when we are negotiating for pandemic treaty, so that we do not leave things to discretional gestures, be it around financing, be it around technology transfers and IP transfers. Like what FIFA was sharing, of the 20% donation. The word donation does not inspire a lot of confidence. We know what happened during the COVID response. Act A, was created with a lot of promise. But at the end of the day, we know what was delivered against what was promised. And that demonstrates that in as much as goodwill is a good talking point, but it's not bankable, tool to deliver on important things as PPR agenda. And therefore, we must really rethink our normative framework. And that's why this INB conversation towards creating a pandemic accord is important for Africans to make very clear their demand. And I like that assertion, even as the way other countries are drawing their red lines, even as we need to draw our red line, like if it is not promising a transformative framework that would help shift the needle in the direction of equity, then why have it? It's just putting a discretion, vocabulary language in a very expensive paper, for example, and having a very protracted process, but with the same arrangement that we've had that have failed us before. I don't think that would be worth our time and would create the kind of agency that is needed to really push for things in the direction that they need to be. I think what we have learned is that human rights and public interest needs to be at the center of all these considerations and not any other considerations. Market-driven innovations and evolution of capacities have shown their weaknesses and limitations. We know Africa is full of a lot of challenges. There are lots of outbreaks currently, a lot of empty pipelines for diseases that are endemic to Africa without commensurate investment. This is something that must be considered, in terms of negotiation, because they are empty pipelines because they do not have market potential. Yet they portend, global threats to our, health security. And that is something that should bother people. We've seen how diseases that have been very endemic and in Africa for a very long time, have remained unresearched and do not have countermeasures until they crossed borders and went to the other side of the world. We're talking about mpox. We are seeing what's happening with cholera, where we are now being told we don't have enough vaccines. Yes, vaccines have been developed for cholera. Countries have been battling cholera for the last 1.5, nearly 2 years, countries like Malawi and a number of Southern and Eastern African countries. This just shows how we must reconsider our engagement in this discourse. There's this prevalent argument around return on investments, which is a very market-based approach. And what I've heard citizens say in most of our conversation that this return of investment is important, but it's only important when all lives are valued equally. Sometimes when diseases are impacting in other regions, it is not considered as an issue. People are dying in their thousands, but when they touch the other parts of the world, that's when we see some action, even if they're 10 or 30 people. That means our lives are not valued equally, and therefore our parameters of really measuring return to investment must change, and we must drive that narrative in ways that do not innovations and efforts around what dollar gains we get from availing tools and technologies to support human safety and security and health security. So I agree with what have been said, and I think what I would emphasize is just urgency and local ownership. We need to really make our story important as it is for the other part of the world. I think Africa must demonstrate leadership instead of always crying foul. We must demonstrate leadership by operationalizing this epidemic fund. We must demonstrate leadership by operationalizing Partnership for Africa vaccine manufacturing. We must demonstrate leadership by, really allocating resources to provide the necessary human resource that can help us manage these challenges that we are facing, and really make very concrete and reasonable demands from our partners, so that relationships that are going to be formulated going forward are in line with the Africa vision for new public health order, respectful and productive relationships. Thank you.
Thank you so much, Agre. That was a great note to end on. Completely with you on that. Self-reliance is the key, and we can't rely on other people to donate as they have in the past. Off to Jim to lead us off.
Thank you so much, Sam, and thank you, Agre, for really wonderful closing remarks, and thank you on behalf of your organization, RANA, Resilience Action Network Africa, for co-sponsoring this, and our other co-sponsors, WACI Health and FITSM. Thank you so much. For everyone on the call and over almost 300 who registered, we will be sending you an email soon when this recording is online. That'll include access to a resource document, and we'll also put the transcript up so you can look at the transcript as well. So look for that soon. I hope you'll join us on March 26th for our conversation on decolonizing global public health. And I just want to thank you all for spending time today and for grappling with all these really important issues. Wherever you are, have a great one. And we will see you online, on Zoom, somewhere, hopefully very soon. Take good care.
Thanks, everyone. Have a good day.